Hello, welcome back. So we move for the 11th procedure that will be done by Schalk in Leuven, Belgium, and will be moderated by Linda Lee from Boston, USA. Schalk, can you present the case?
We have a patient with chronic pancreatitis that presented for the first time in March of this year. It seems to be chronic idiopathic pancreatitis. The patient uses no alcohol, there's no family history, and he is a smoker. But apart from that, we do not have an etiology. The patient has on MRI a clear stricture in the corpus of the pancreas with upstream dilation, although, as you can see, the upstream dilation is minimal, and it's going to be very tricky for us to gain access. ERCP was tried on 2 occasions, but retrograde cannulation failed. This patient continues to be symptomatic. He's 45 years old, and he would prefer minimally invasive therapy, as the option for him would be surgery and probably a pancreatic tail resection. So it's a tricky case of chronic pancreatitis and inability to cannulate. With me in the room is Dr. Braunzweig, and I'm going to ask Michiel to just talk about the previous studies on surgery and endoscopic therapy and why he thinks that surgery failed in these cases as well.
Yeah.
Endoscopic therapy failed in these cases, sorry.
I think we're showing the PowerPoint at this very moment, but one of the most, I think if you show, if we can now go to the endoscopic ultrasound image, because we can have a nice clear view of the stone here. But as Schalk said, a couple of trials have been done comparing ERCP or endoscopic therapy with surgery. But especially the study by Cohen or Dutch colleagues, what we saw was that endoscopic therapy often fails. So almost a third of cases, even cannulation fail. And also newer trials, also performed 2 years ago, have not included US-guided pancreatic duct drainage. So in the historical studies did not include these extra tools we have now. And I think we hope in the future that these results of endoscopic therapy versus surgery will come out completely different, because the main reason for endoscopic failure is now perhaps mitigated by EOS. And of course, something we don't need to underestimate is also the advent of pancreatoscopy. So the spyglass lithotripsy has also helped us in clearing the ducts. And I think comparing complete ductal clearance with a backup of EOS, I think versus surgery, this will be our new 2022 design for a study. So it would be nice to see what our new approach, how it does it compare to surgery.
So you can see that there is a pancreatic duct that is very multidilated. And the principle would be for us to cannulate the duct and to facilitate antegrade rendezvous. So you can see the duct over there. The needle will be coming from the left top. In this case, we already used the 19 gauge, and we found it very difficult because of the degree of calcification of the pancreas. And now we will insert. You can see the needle, I think, going nicely into the duct.
Beautiful.
Is that clear to everyone?
It looks easy, but the amount of calcification and the overall stiffness of the pancreas really makes it very difficult. The 19 gauge needle is almost impossible to get through. So we now have the fluoroscopy here. If you can switch to fluoroscopy for you.
Can you comment on which 19 gauge needle you're using? We
use the 19 gauge of Mediglo, but also tried the 19 gauge of Cook, and we now switch to the 22 gauge Cook needle.
We had incredible difficulty passing the 19 gauge needle, and based on that, we elected now for the 22 gauge needle and see if the rendezvous procedure is possible with a 0.018 guide wire. In the event that it's not possible, I think I will try in this position again with the 19 gauge, because it's a little bit closer than I had previously. So if we can advance the wire, you can loosen the. Okay.
So this is the 22 gauge needle, just to be clear.
So as we also wrote in the ECE guidelines, I think it's preferable to use a 19 gauge needle. I think it's preferable because of the fact that if we need to perform use a cystotome to create a tract between the stomach and the dilated pancreatic ducts, then it cannot be done using the 0.018 wire, as it does not conduct current. So this requires us to use a 19 gauge needle. But if we are lucky enough and the wire is going to pass into the small bowel, then we may use, as we are doing now. So there you can see we are passing the wire into the pancreatic duct. We will be manipulating the wire until we know that there are many stones in the duct. So it would be important for our endoscopic nurse to use all her skills. If I will, and there we go. So there you can see it passing into the small bowel.
This looks far more easy than it really is, because this is very, very challenging and very nice.
Perfect. Yeah, it's beautiful. And are you hoping to do a rendezvous, or?
Yeah, so there's no studies directly comparing rendezvous with a pancreatic gastrostomy, but the overall consensus of the experts and our guideline also is that you should go for rendezvous, because you have the potential to prevent a lot of complications, and also draining something from the classical anatomical route is a lot better than making another one. So we've nicely placed here the guide wire and looped it inside the duodenum, and now it's a trick to keep everything nicely in place and switch for the duodenum.
So I'm going to show you the technique of, we have to be very careful now, because we want to leave the wire behind. We want to extract the endoscope whilst leaving the wire behind, and then we will insert a duodenoscope and advance the duodenoscope without wanting to displace the wire. So you can see I've called up the wire a few times. This gives me some security, but we still have to be very, very careful. So if I will demonstrate the technique, we will very carefully pull back the endoscope while I advance the wire. This is the new therapeutic ultrasound endoscope from Fuji, which has the benefit, very careful, which has the benefit, yes, come back, of being able to lock the wire should there be a need to do it. And I need to therefore be careful that it is nice and open, so that we do not inadvertently pull the wire out.
Yeah, I think the coordination between you and your nurse or technician is so important here.
Absolutely.
It's always important, but in this situation, crucial.
Absolutely. This is always very anxiety provoking for me. Now, I know you guys were saying you're using an 018 wire. There's a question from the audience asking which type of wire is it?
So this is a 018 wire. I can now just see, and I'll show the wire to the audience here from the package insert. We're just going to exchange for the duodenoscope and remove the echo endoscope. So we're using the 018 inch Roadrunner. But as I said, although it's a wire that one can manipulate through a 22 gauge needle, it does not allow for passing of a cystotome, because it does not conduct current. So this is the 0.018 Roadrunner made by Cook. So we find it quite useful. But as I said, if you are unlucky and you have to manipulate and you cannot pass the stricture as we could in this case, then you would need a 19 gauge needle plus at least a 0.025 wire, and very often also have to use a cystotome, especially if it's difficult to pass the stricture. To give you some more to help you to manipulate past an important stricture, you need some stability, which a cystotome may provide you.
Yeah, you're very fortunate to have that 6-French cystotome there, because we unfortunately do not have that in the US, and we're very jealous of that, I have to admit.
What would you use instead if you're in this predicament in place of the 6-French cystotome? What would your strategy be?
I mean, needle knife, because that's all we have. And of course, some people have talked about using the hot axios, typical hot axios, which are very, very expensive.
I've seen a couple of cases of small hot axios indeed, but there's nothing wrong with trying to dilate the tract with a small caliber balloon, of course. So
yes,
in many centers where the cystotome is not available, you can still use a dilation balloon, but it's more cumbersome. And one of the other advantages of having a cystotome is that if it's difficult to perform a rendezvous, and this is often the comments we get, if it's very difficult to transverse the papilla with the or the stricture with the guide wire, you can use the cystotome as a stable platform to push it through.
Yes, yeah, no, I agree. I think first we try to use a hurricane dilating balloon to get through, if we're doing a pancreatic gastrostomy or something. But if that really does not work, then we'll revert to the cautery devices that we have in the US.
So if we can switch to the endoscopic screen for a second, the endoscopy. Schalke is now carefully navigating the scope alongside the wire to the papilla, and it will be interesting to see and exciting to see whether it will be the minor papilla or the major papilla where the guide wire went through. Because in the CT it was not clear to see.
And comment, have you guys used rectal NSAIDs in these cases?
Yeah. Although the fluid trial also was negative for hyperhydration and prevention of pancreatitis, we also use a little bit of hyperhydration. But in every case, we do like this, definitely rectal NSAIDs. Yeah.
Yep, why not? It may help.
I think the main prevention of pancreatitis will be making sure that the PD is drained. That will be the major factor.
Okay, so there we can see the papilla, and hopefully we can now nicely cannulate next to it. That's always the easiest. In the event of failing, then we would extract the wire, but that's always more cumbersome. So we'll see, we've got two options now. The first option would be to cannulate. The second option would be to perform a precursing craniotomy over the wire, and then afterwards we should be able to cannulate more easily. But let's see if this is not sufficient. So therefore we'll gently there we go. I'm just very carefully going to see. Now we'll switch to the fluoro image. We're going to see if we very careful. I'm just going to come a little bit closer to Opswana. There's Opswana. Okay, so we're just going to see
a nice
how we should be able to manipulate the wire very carefully.
Looks promising.
Looks promising. It's in the vicinity where it should be. Okay, I think you can just release your tension on the top of the catheter. I'm going to ask that if it gives me a precut, I think it's going to be easier if we just open up the papilla, and it will allow us to more easily cannulate. So precut, I think will do the trick. That's fine.
You can see that we are switching quite quickly to a precut.
Now, earlier you were talking about in this young man that he really preferred the minimally invasive approach and did not want to have surgery, correct?
Yes.
What if, he was, a different situation where he was not demanding a minimally invasive approach? In this kind of situation, would you have recommended a surgical approach first in this very young person with chronic pancreatitis as opposed to the endoscopic approach? Or
I think it's about discussing the options, and it's about shared decision making. So we would still be in favor of endoscopic therapy because we've got quite a series now and extensive experience using EOS guided rendezvous, and the outcomes are remarkable in terms of clinical success as well as technical success. Maybe Michiel, who is the primary investigator of that trial, if you want to comment on that.
Yeah, so I think we now compiled a series of more than 50 procedures, 50 EOS guided pancreatic gut drainage procedures, and what we see is that the technical and clinical success are quite high. Of course, there are still a couple of patients who fail also EOS guided access. I think those patients, those are the ideal profiles that you perhaps should consider surgery. And of course, the comparative trials versus surgery have always been in favor of surgery with the lower EZBT pain scores. But still, I think this should be more of a step-up approach. If you fail endoscopy, then go for surgery probably. And also, one of the major comments we always get is this a safe procedure? And what we see is that there is a higher adverse event rate compared with other therapeutic EOS procedures. So I think in our series it was around 30% adverse event rate, but it is very important to say that most of those adverse events were mild episodes of abdominal pain. So it's not crazy to think that these patients perhaps will have a little bit of a discomfort, but still the major and severe adverse events were still limited.
Yeah, so kind of analogous to how the treatment of walled-off necrosis has evolved to the endoscopic step-up approach. So kind of analogous situation here, it seems.
I think with all these advanced procedures, doing these procedures, you should have a kind of a flow chart in your head. If this fails, then we go to that. If this fails, we have this as a backup. I think this is important to have in your back of your mind.
Okay, so we've now cannulated the pancreatic duct, and we will.
Beautiful.
We can inject some contrast to define the anatomy. So
now, while you're injecting contrast, there's a question from the audience where they ask, why don't you use the wire for cannulation instead of precut?
Well, we've tried that. So that was first used, but it wasn't so easy to cannulate next to the wire. The alternative would be to extract the wire. But this is a very fine wire. It's very difficult to extract the wire. We even capture the wire with a snare and put it through your scope. So we wanted to not to need to do that, rather cannulate next to the wire. So now that we're in a good position, we know that we will not use our position anymore. So we can remove. I'm going to ask if I'll leave to remove the wire that we've placed transgastrically, and then we can work only from the wire that we've inserted. So in this case, we will normally now insert a stent that we will do today. We will bring the patient back for spyglass in a couple of weeks to also remove all the intraductal stones that we know the patient has on the MRI, so as to be able to get complete ductal clearance. So in the event of complete ductal clearance, these patients do very, very well, as Michiel said, with sustained responses of approaching 80%. So I think this is going to be the game changer in the future, where in the past we used to compare chronic pancreatitis just placing a stent to surgery. The new I think, way to go is to confirm that that not only do we want to gain access, we want to manage the strictures, but we also want to remove all stones and then use stents to maintain patency until such time as the stent can be finally removed. And that should be compared to surgery. Otherwise, the outcomes are not as promising as the Cayenne paper showed, with favoring surgery as an approach. But with complete ductal clearance, I think it will be different. So now we will perform a pancreatic duct synchrotomy, just extending the pancreatic duct so that the stent can be easily placed. I think we can see, and this is important, we can see, and this should be done adequately so that you have adequate drainage and where you can place in the future multiple stents and be able to go back. So I think this we should perform an adequate pancreatic synchrotomy, not just minimally, because that will only lead to fibrosis later on. So now I'll come back, I'll leave the guide wire behind. We will dilate the distal pancreatic stricture and already attempt to remove some of the stones, although that should be done in the next session, because I've got no doubt that we will need spyglass lithotripsy to clear the duct. This will not be possible with endoscopic therapy and baskets without fragmenting the stones.
You said it. So there's nothing wrong with doing this in a two-step way. An important point is that we don't leave too much time between the stent placement now and the revision with the spyglass. So we tend to call these patients back after a couple of weeks already.
Can you comment on the use of Eswell versus SPY with lithotripsy?
Sorry, the use of SPY?
Extracorporeal shockwave lithotripsy versus SPY.
Yes, we do use that. I think we are a referral center for ESWL. We do that if there is a dominant single stone. In this case, this is not going to be useful, because the pancreatic duct, as we could see on endoscopic ultrasound, pancreatic duct is absolutely filled with multiple stones that are not visible fluoroscopically. So unfortunately, ESWL is not applicable in this setting. But if we had a dominant stone, a dominant large stone, that would be the first approach, would be to manage the stone first with ESWL therapy.
There's, of course, an important side note for ESWL is that ideally you need a radiopaque stone. And also another important point is that it's quite operator dependent. So you need someone who does it often, has the right settings to have a high success rate.
Okay, so now we've passed the stenosis, and we'll start here to dilate. We'll dilate with a 6mm dilation balloon. 4 is fine, and then we can go to, I think, let's see if 4 is appropriate for this case, but I think we probably can manage 6mm, and then we'll place a 7 French stent, 7 French 9cm stent in the first instance, and then bring the patient back, as Michiel said, in a couple of weeks.
Now, you've made this procedure look so easy, but these are not easy procedures. And I was hoping you could comment on the learning curve of learning how to do these procedures.
I think it's a very important point. These procedures are not easy. I think it takes time to accumulate the skill, and but I think it's perfectly possible, because we train our fellows that come for interventional endoscopy in these techniques as well, focusing first on the bile duct, and if the proficiency increases, we will also train them in pancreatic work. As you can see, I think what made this procedure difficult was that the pancreatic duct was not all that dilated, and it was quite difficult to recognize against the severe parenchymal calcification to recognize the duct. So the combination of the two made it more difficult. If you have a pancreatic duct that is beyond 5 or 6 millimeters, it's normally not that difficult. In this case, the pancreatic duct was, I think, 2.3 or 2.4 millimeters at the level where we inserted the needle. But you're right. I think that does take time, and one should start with the easier procedures first.
Mm-hmm.
So we'll now dilate with a 6mm balloon into.
You perhaps saw that the 4mm balloon just broke because perhaps of a hard stricture, but we switched to the 6mm now. So this is the new balloon. You saw a little bit of a contrast flying everywhere.
Okay, and now I'll also, that's fine, I'll dilate across the papilla, and then we'll insert the. So there will be an overlap in the dilation.
It's also very important to overlap.
The 7 French stent. Okay, you'll see that there's a bit of bleeding, and that is to be expected. I'm not concerned about that, and the pancreatic orifice is nicely visible, and the synchrotomy is adequate, so that we the next time will not have a problem going back with spyglass. So I think that basically concludes what we have to show after the stent placement. I don't know if there are any more questions that we can answer.
So there is a question from the audience asking about, what about placing multiple plastic stents side by side now, as opposed to a single stent?
Absolutely. I think that would be the next intention. In the first instance, I want to get access. The second would be to go back with spyglass to inspect the stricture, to remove all the stones. And at that time, we will start with multiple stenting. We'll place 2 7 French stents. And then from there onwards, based on the size of the pancreatic duct, decide how much room there is for stents. Normally placing 1 to 3 7 French stents, and then leaving them to be exchanged every 6 months until we get complete resolution of the stricture.
What do you think about the stent length?
Sorry?
What do you think about the stent length? Would be 7 be okay, or do you?
I think we ought to go to 9, so 9 centimeter.
I have to apologize to the nurses because I said 7 centimeters.
Sorry, I missed that in the field. Otherwise, I would have.
Very good. You want to make sure
I do expect that the 6 French cystotome will ever become available in the States, because I think it's really a crucial part of our procedure in the event that we cannot pass a wire.
I agree, and I don't know why we don't have it yet, but I 100% agree with you. There's another.
We can always import that on the black market for you if you just let me know.
I'll send you my address offline. Would love to have some of those. And there's another question from the audience. Any experience with using biodegradable stents?
Yes, we published a couple of years ago a paper on biodegradable stents where the outcome was fairly positive. I think after that there was sort of a lack of interest, which seems to be reignited over the last year or so again, especially in the setting of biliary work. But that is a very good suggestion. I think, especially if the duct is completely cleared and you want to be sure that the stenosis remains patent and you don't want the patient to have to come back for multiple stenting, then that is certainly an option. I think that we have a stone there, which you can see, a radio stone that is precluding us despite. So we may even have to consider performing, if I can't get the stone past the stone, we have to consider doing spyglass today because we need to drain the duct. And if the stent doesn't pass, then that would be a concern. You can see that there's stone now visible.
And what about switching to a 5-French stent?
Yeah, that is an option. But it would be unfortunate if we cannot. At least it's going to be difficult. And to further dilate with the balloon is not going to solve the issue. So we either have the opportunity now to place a smaller stent or to perform spyglass. And although this is not a spyglass meeting, I think that is what we ought to do for this patient. So maybe if, I know that you cannot stay for that part of the procedure, but I think we ought to, in the interest of drainage in this patient, rather do a spyglass procedure. So if you can get the spy scope ready for us.
Well, this is a beautiful example of what happens in the pancreas, right? You just never know.
Absolutely.
And have to be prepared for anything.
Yeah, we're moving to the other side of the flowchart in our head now.
Yeah, we certainly are used to having to have a plan B and C and D when the others fail. But yeah, because it's just because we've underestimated the stone. We saw that. We saw the stone. Unfortunately, we could pass with a wire and still gain access. But I think we underestimated the size. So if you have a few minutes, maybe we can show the stone on a spyglass. And I don't know if that is possible. Otherwise, we will have to continue whilst you continue with the program.
I will have to defer. I would love to see that, but I will defer to the other folks here if we can keep staying here, if we need to move on.
So it depends a little bit whether we can connect the spyglass to the system for a second. We extracted the stent and the guide wire. This is not a big issue because the PD access has already been facilitated with sigmoidal balloon dilation. We just have to fish out the stent here and do that.
So while we're trying to get the spy set up, there's a question from the audience here saying, if this patient's duct was not that dilated, will doing this even help with his pain? Is their question. And he has stones in there, so hopefully taking the stones out will help.
Yeah, well, this patient clearly has a stricture. I think if you had seen the PowerPoint slides, it's very clear on the PowerPoint slide that there's a really dominant stricture with upstream dilation of the pancreatic duct. Although the pancreatic duct is not that dilated, today on EUS, it still is very clearly visible on MRCP, which so that is also the indication for performing this procedure. I think the management of patients with a normal duct pancreas and chronic pancreatitis is really very different. I think that's a different disease probably, and it should also be managed differently. And there, endoscopic therapy probably does not work that well.
And also, you don't need to wait before your PD has dilated up to 12 millimeters. If there are signs of ductal hypertension and stones, there will be a stricture.
Yeah, no, I agree. I mean, the MRCP was a beautiful demonstration of the stricture there, plus the stones, of course.
And it's also important to know that we not only rely on MRI, but especially for stones, CT is still very useful.
Yeah, no, absolutely, because the MRI, you can't really see stones very well, so you need a CAT scan. But also, perhaps his duct can't dilate all that much because he has such horrible chronic pancreatitis, you know?
Yeah, I agree with you. I think that the degree of parenchymal calcification is really extensive in this case, and that may be the reason why the pancreatic duct does not dilate beyond the
Right. So I'm hearing that we are going to have to leave soon, unfortunately. But hopefully we can see a little bit of this.
I think that I've been hearing in my ear that you guys will have to go.
Yes.
But maybe we can record some of it and show you later.
Wonderful.
So we have a change in the program, Schalk.
Say again?
We have a change in the program. So I will start my procedure. And then there's going to be a switch from Napoleon, but I'll write you later. So I start with my procedure. I'll present myself and the moderator, don't worry. So if you need to finish the procedure, go ahead. I want, again, really thanks Linda, because she was really very, very nice, and she agreed to change and to be with us early morning. So really thanks, Linda. We hope next year we need more women also performing. So we need, we are embraced by the women in endoscopy. So we need you as a performers. Okay.
My honor to be here. Thank you so much. And that was such a beautiful, beautiful demonstration, Schalk. Thank you.
Thank you for the
very much.
Bye-bye.
Congratulations.
Thanks.
So the next case is a 80-year-old female. She had a previous myocardial infarction with 3-stent placement, chronic atrial fibrillation on oral anticoagulants. She had 2 previous episodes of acute biliary pancreatitis. MRI showed no choledocholidiasis, but the presence of multiple gallstones. So the scheduled procedure is elective EOS-guided gallbladder treatment.
Hello, everybody. Welcome back to Rome. So this is a sort of a new indication for LAMPs. that is a elective gallbladder treatment. So we move from treatment of acute cholecystitis to more chronic diseases. And as you can see, this patient is a patient at high surgical risk, so he has a cardiac coronary artery disease, atrial chronic atrial fibrillation. And if you think about the population is aging. So people get more and more old, and with age, there is an increase of the prevalence and the incidence of Boston disease. So probably, I think this is, in my view, is an important indication that can grow exponentially, and it allows you to do procedure not in acute phases, so not in the middle of the night, things that I don't like to do, but whenever you come. So this patient has a history of 2 episodes of acute biliary pancreatitis demonstrated by elevation of ALT, AST, and bilirubin. They never did an ERCP because at the end all the labs went down the day after. So we did. She had an MRI that showed no stones in the bile duct, and we checked for stones later on, and there were no stones. If you can see the image, or the ultrasound image, so you can see we are in the duodenal bulb, so you can see the gallbladder, and you can see small, risky stones. That these are the ones who probably creates more problem in terms of acute going from the cystic duct into the bile duct and then causing acute pancreatitis.
Good morning from Orlando. This is Mohammed.
Hi.
Hi, how are you?
Good, you?
Good. This is you're talking about the indication on this particular patient. Obviously, there are a few. We could have other indications as well. So I really like your description the way you described it. This is in this particular patient, which is with sick and elderly patient. Don't want to go through surgery. Are not a candidate for surgery. What other indications would you consider this procedure?
So we have a paper almost finished to send to GATT, where basically we enrolled 44 patients. 43 were followed up. Technical and clinical success was 100% in cases, and the patient were like this one, acute pancreatitis, or patients with big stones and quality pain, so chronic quality pain related to stones, or the patients who had mild cases of cholecystitis that were never or hospitalized or went for the hospital to a couple of days, and then they got antibiotics, and then they stayed they got better, and so they left, they were discharged, and maybe 1 year later they had a similar episode. So these are part of the group of patients that we usually treat. So so the debate about where to perform the drainage for the gallbladder. If you have a gallbladder, a patients who are still surgical candidates, it's better to do from the stomach because then the repair of the hole is better from the stomach. It's easier from the stomach than from the duodenum. If you have a patient with a definitive treatment, it's better to do the procedure from actually the duodenum. So I will check for, but at the end it's better to do the procedure from where you see better the gallbladder. So this is the gallbladder. You see there is a big stone also. What I try to do usually, in these patients, I try to be less aggressive. So I try to do from the stomach because after 10 days, I go back, I go inside the gallbladder, I see if there are still stones or if there are big stones, if they need intracholecystic lithotripsy. And then when it's finished, when everything is finished, I take out the stent completely. So from the stomach, it's easier to get into the gallbladder. And another tips, I think, is to use a big stent. So if you have small stones, usually people use the 10 millimeter stent, but I found that many stones, anyway, they don't come out. And with the 10 millimeter, it's very difficult to get into the gallbladder. So I usually use a 15 millimeter when it's axios or a 16 millimeter when it's the spaxos.
So Alberto, you're going to try it from a stomach. So one other thing is if the window is really close to the pylorus, what precaution you take? Because if you are using axios, it opens up. There's a risk of it coming over the pylorus.
Yes, this is something you have to take in mind when you do gallbladder drainage to try to avoid to release the stent into the pylorus. It is also true that you think that you are not in the pylorus, you are in the stomach or you are in the duodenum, and then maybe you move a little bit without being conscious about this, and then you release the stent close to the pylorus. So sometimes it can be very difficult to avoid to be close to the pylorus because it's not a static procedure, but it changes and you make maybe small movements that you think do not affect your vision, but they affect actually the. So here you can see that the gallbladder from the stomach is pretty close to the pylorus. You see? Let me see if I fill it up, because if we go also from you see?
Yes.
So we can see here.
Yes, we do see the pylorus.
So this is, but here is okay. You see? Because the pylorus is there, and here I'm in a good position. I have to see if I have enough contact with the gallbladder with the wall. So here is okay for me.
What stent are you using?
So we're using the Spaxus 16 by 10. So here should be a good, but I can go back to the duodenum and check it again. You should not hurry up. There's no need to hurry up. Here. So the duodenum, this is still the bone. Also from the duodenum. Okay, this is the duodenum, so it's pretty good. Let me see how big it is.
So now you're checking that distance from the gallbladder wall to the luminal wall.
That one I'm not interested in more. I'm more interested in how big is the gallbladder to see if the stent. So the distance between the wall and the gallbladder wall is 50 millimeters. So I think it's okay. So I think this is a good position. So I hope I don't have the same problem as before.
What would be that? What would be that?
I hope not. Let me see. So the catheter of the Spaxus is softer than the coaxius.
So that went in well?
Aspetta, wait. Okay, so we're inside.
Mm-hmm.
Let me see. I'll show you the catheter. Okay, we start opening. It opens. So the stent has a different shape.
Mhm.
It's open.
So you're watching both with the US and endoscopically there.
I watch the US because endoscopically now you don't see anything.
Yep.
I don't see the. Continua ad aprire. Aspetta, 1 second. I don't see the. No, it has a different shape. No, sto venendo indietro. I don't see. Okay, so probably here we can see we can start seeing the. So we are going to look the endoscopy. Aspetta. So it's the distal flange is still not open, but we're going to release anyway the. Okay, it's probably opening now. So I think we. Yeah, c'è lei il marco giallo. Secondo me stiamo scendendo. Esatto, quindi. Dove? So we're doing under endoscopic view.
Yep.
So. Ma guarda che vado nel bulbo, non esco più rischio di andare dentro il bulbo. Che dobbiamo fare? Non posso uscire questo strumento perché vado nel. Siamo nel pilone, capito? Vedi, scatta e lo perdo. So we are releasing the proximal flange. Piano.
Okay, good.
Let me see, 1 sec. You see what I was saying? I mean, gastro. That we aim not the pylorus, but then it ends up. But this is gonna flat. You see there is bile coming out. So what I learned with time is that you need to know. I usually do everything under endoscopy under US, but then you need to know also in certain cases what you have to do under endoscopy. In this case, the space was not too big, so probably the distal flange is going to open. Probably now it's open, but it didn't open that much at the beginning. But if you secure the stents opening the proximal flange, everything is fine. So I don't think we need to watch it. So we were. What we're going to do, the stance is different from the axios, so it's not going to stay like this, and these are 2 centimeter stance. So in this case, it's going to shrink, and then the flange is going to juxtapose to the duodenal mucosa and to the mucosa of the gallbladder. So if you look at the stance tomorrow, it has a completely different configuration.
Yeah. So well done.
I can see, I can see now the stance from inside.
Yeah.
From the US.
Yes.
So this is my teaching. Also, I teach to open little by little. I also think that who comes from working with axios since 10 years or more, it takes a little bit of time to adjust to something new, especially something that needs to be controlled with the help of somebody. So it's basically a biliary stance, even though they work on a handle too. But I think you need to know how to use all these stances because there are situations where one is better than another. Because, for example, this is 2 centimeter long, so sometimes the target is more distance than 10 millimeter as of course for the axios. And then, for example, there might be the problem of bleeding. We have performed a propensity score study retrospective with more than 322 patients, and we found that this stance has 5 times less risk of bleeding before the configuration. So I think we need to learn to use all the stents to be able to to choose. It's like when you have to fix a car, you don't have to have one thing. So you need to have more because you need to have all the measurements and so on. So if there's any question,
so Alberto, well. On that, and here in the US, we have mainly only axios available. And as you mentioned, the length of the stent really matters too. We have 10 millimeter long. We have 15 millimeter long, and so we usually deploy both the whole stent, proximal as well as distal end under the EUS images. And the question I have for you is about these. In our experience, what we think is like these axial stent, they behave differently when there is a communication between 2 epithelialized cavities, gallbladder as well as either stomach or duodenum. So what I'm getting at is, in your experience, what is the risk of bleeding with this axios? And the second question would be, when would you consider removing it? And that would be based on the indication if to remove or not to remove. So risk of bleeding and when to remove those.
Okay, so I think the risk of bleeding is really only in pancreatic fluid collection. If you think about capillary lesion bleeding, if you have bleeding by transversing vessels while you enter, is a different story. I think that the way to take care of the stent, it depends on what the patient has. So if the patient has, for example, a complete fluid collection, I usually take it out after 10 days, and then I put a double PK stents. I follow up about what Varadayu just published. If I have, I don't do repeat imaging. So I bring back the patients after 3-4 weeks, and if there is necrosis, the necrosis was at the beginning. I see the cavity. If you can clearly see the wall of the cavity, I take out the stents, and that's it. If I still see a certain amount of necrosis, I try to take it out as much as I can, and then I bring it back the patient after a couple of weeks to check if he needs more cleaning. I usually, if I have a wallet of necrosis, I usually place 2 Mediglobe 8.5 double pigtail stents 2 centimeter, and it's not only to protect from bleeding. We know that there are two papers with conflicting results, one from Spain and one from the United States, where and it's not clear if really the pigtail stents in willing pigtail cells helps against bleeding. But for example, if you have a patient who arrives as necrosis, but is not so sick, so you drain and the patient feels better, I place the stents also to try to keep the opening, the southern part of the lamps opened to avoid clogging of the middle part, and then clearly infection and fever, so the patient has to come back. There's no data. I have no clinical data to support this, but I think it depends also on your environment, on your setting. In my setting, I try to send the patient at home as soon as possible with instruction, with the stents, and with instruction to come back in case the fever can start.
Yeah. So that's the bottom line is the axial stent between two epithelial cavities behave differently as compared to between necrosis or pseudocyst and luminal wall. So what you're saying is this, we know that the risk of bleeding with necrosis and a non-epithelialized cavity, but really no major risk of bleeding when you are connecting gallbladder to the stomach or the duodenum. And in those cases, you can leave the stents for a long time, really. If a patient is terminally ill, not a much longer life expectancy, 6 months, 12 months, you probably can leave those stents in. And also based on patient may not want to have another procedure. If, however, the indication is some sort of benign, a bridge to surgery, in those cases, either it could be taken out at the time of surgery or it could be removed even endoscopically. But it is much safer to keep that in for a longer period as compared to when you're using it for necrosis indications.
The data about bleeding is really, confusing, So I think to really clear up about the bleeding related to axios, I think you would need really a multi-center study perspective, only focus on that aspect, because there are people who takes out after 4 weeks, 6 weeks, 8 weeks, 10 weeks. So most of the data retrospective. So the data by Shyam with the randomized control trial, in theory, he had these things about taking out the stents after 6 weeks. Then he had a lot of bleeding, but if you look at the bleeding, the 2 or 3 occur at 3 and 4 months. So when you usually take out the stent, so I think there is a risk of bleeding, but if you think about there is a risk of bleeding also with plastic stent. So I think there's data with the plastic stent that actually they look worse than the lamps. So I think there's unfortunately on pancreatic fluid collection there's a lot of chaos. There's no homogeneity of how to perform the procedure. There's no homogeneity on how to follow the patients and so on. So I think we need to come up with something and then perform a study because or otherwise we can continue to do like this. So I have to leave. Thanks, Mohamed. I hope that the hurricane didn't touch you.
Thank you so much.
Thank you very much, Mohamed.
Well done.
Thank you.
Imagine a world where everything is designed to maximize value, enhance experience and satisfaction, and improve clinical outcomes. With our innovation hubs, we are driving innovation for the future. Our intensive research and development employ the insights from clinicians worldwide through our Black Box Innovation Program. Our latest invention, Discovery, is an innovative device using artificial intelligence to support you by directing your attention to unremarkable potential lesions. Our EUS J10 lineup is designed for optimized procedural efficiency during diagnostic endoscopic ultrasound, FNA, FNB, and therapy. And there are further unique innovations, for example, under our Pentax medical hygiene commitment. Like the DEC duodenoscope, its single-patient use, sterile disposable elevator cap helps reduce the risk of cross-contamination. And the Plasma Typhoon and Plasma Bag system, a unique solution for fast-drying and active storage of endoscopes. By using this system, confidence in the safety of reprocessing outcomes can be greatly increased. For your therapeutic treatments, Pentax Medical develops state-of-the-art devices, such as the multifunctional Splash M knife. It allows clear marking, effective hemostasis, as well as smoother and easier ESD procedures with a single device. Another example is the K-snare, with an adjustable knife on the tip for precise marking and incision, combined with a snare for resection. Or like the Hemostat Wide Cup, that enables fast and efficient hemostasis through its unique bipolar technology, providing less impact on deeper tissue. These are just some of the many smart innovations that make a difference in your daily work, inspired by the Pentax Medical Triple Aim. This is the world of Pentax Medical. Welcome to the world of intelligence.
Hello, Bertrand. Hello.
Yeah, do you hear me now?
Yes.
Okay, perfect. I hear you perfectly.
Perfect. So we have a change in the schedule, and not only in the schedule, but also in the patient. Bertrand was showing a very nice case of a cyst with a suspicious of a net, so with a thickened wall. But in the meantime, the cyst, the thickened wall grew, and so there was no more fluid component. So it was not really fit for the Moray microforce. But it was very clever because it got at the same time another patient for the procedure. So we just have to switch. And so I don't know anything about the patient, so you need to present the patient, and I will moderate this session with you.
Okay, thank you, Alberto. I'm not so sure I was clever, but you will see. So it's a 61 years old woman, incidental discovery of pancreatic cyst, very anxious because her mother died with pancreatic adenocarcinoma. Herself had no symptoms and no history of pancreatitis. It was described as a large cystic tumor, 4 cm large, still at the pancreas, no evidence of communication with the Wirsung duct, and the MRI suspected first and serous cyst adenoma. But there were also small cysts 8 mm in the head with the communication, so they prefer to send the patient for a USFNA and biopsy with Moray forceps. So I will show you the image we have. You see first that, as usual, you have to check the pancreas for all these cysts because it could also always be a pseudocyst. It's very rare if the patient had no past of acute pancreatitis. Nevertheless, you must check if there is not signs of chronic pancreatitis. You can easily see that this pancreas is, I would say, perfect without any signs of pancreatitis. A nice parenchyma, so no problem with that. And now we will go gently to the body, and you see that suddenly we see a big cyst. A very big cyst. So here I want only to tell you something. Is frequently when I see the sonographer working, the younger, they use very short range, and that is sometimes a real mistake. If I enlarge, you see the range. This very big cyst, if you follow him, in fact, you can see that it is a kidney cyst.
Okay.
You see clearly it is inside the kidney and not close. It's close to the pancreas. I agree with that. You see it's very close, so you should think it's a pancreatic cyst. But when you see such an image, you can be sure that it is a kidney cyst. So unfortunately, it would have been a very nice case for a Moray, but this one is not a pancreatic cyst. So if now we go further to the tail of the pancreas, we see now what is the lesion that has been seen by the MRI, which is very different. You see that it is a large lesion, 4 centimeter large. You see a lot of very small spaces, liquid spaces, so microcysts, we could say, less than 1 centimeter large. An appearance which look like a tumor in some part. You see here, for example, it's almost only tisular. It's difficult here, for example, to say that there is a cyst. So this image should be, of course, a serous cystadenoma. That's certainly the first diagnosis to propose. But you know it's a large one. There is the past of the mother. So you must be more sure if you want really to leave this cyst, because the natural history of this cyst will be to grow. And we know that when this type of cyst is growing, people become very anxious, and very frequently the end is a surgery. So how can we be sure that it's a serous cystadenoma? The question was for Moray. The problem for Moray is that we need to have a space enough large to open the Moray and to get some piece of material. So if I focus on the larger cyst, that is this one, perhaps we'll check it better. You see it. Okay, that's the larger one. The larger one is 15 millimeter large. We could choose it. It's 11 on this side, but I measure it 15. But unfortunately, there is, you see, a vessel which is just in between the lesion and what would have been possible. So the window, sorry, I will leave that. The window is not good to propose a Moray in this cyst because you see here we have the vessel which is just around. You see better there. So in this case, you have to say, okay, we cannot do the Moray here. You can even not do a puncture there. So now if you look to the other part of the cyst, another thing that you can notice, it's absolutely impossible to conclude about the communication. You see here, the pancreatic duct is there, but as very frequently in this very large cyst, the duct is coming just close to the cyst, and after it disappears, you see here, we can't see here, it disappears at one moment because the cyst is too big, and after you are only able to see the pancreatic duct in the tail, which is not dilated, and when you follow it from the tail, it is the same. You will never really see the connection, but you could say it is inside the cyst, but in fact not. You cannot in fact conclude with such a big cyst. So if I summarize, we cannot conclude about communication. It is a pseudo-tisular cyst that is in favor of a serous cystadenoma, but we cannot be 100% sure, and we would want to have a piece of material to conclude. But this part, this bigger space is not a good target for us because the window is not good. So could we find another one space that could be better? Okay, the bigger one after is this one, which is a bit far from the probe and which is also not so big. It's around 1 centimeter, I think. Okay, 30 millimeter. So if you want to use this one, you can try, but I'm not sure we will succeed. We will try. So we decided to help us do things. First, we removed the stylet and we put the forceps instead of it. Because when you have a very small space like that, if you do the maneuver after, when you retire the stylet, then the liquid is going inside your needle, and you have no more liquid inside such a small space, so you are unable to see what you do with the Moray forceps. The second thing we tried is to block the forceps as we do with the confocal microscopy when you use a probe of confocal microscopy. It's this small piece of material which fixes the Moray. So in order to be sure that we will only, I don't know if you see it, perhaps you could focus on me. Okay, okay, so sorry, B. Okay, if you focus, okay, now you push, okay, and you open. Don't know, yeah, wait, si tu peux agrandir encore. You see the Moray is open. Okay, you see the Moray is open. I hope you see it. And as we blocked the possibility to extract the Moray, then it will go outside of the needle only for 1 or 2 millimeters. So it should be enough for this small space. So we can close, we disconnect. Okay. So I will try that, but honestly, I'm not sure that we will succeed. If not, we will have to do a conventional biopsy with my needle of this big lesion. Alberto?
So you have a difficult task, no? Because
I agree.
So,
it was not the best surprise of the day for me.
But you know what? It's also good to see, you know, that you plan something based on a review of the imaging and blah blah blah, and then in real life you find it good.
Okay, am I inside?
Yes.
Perhaps. Should be. So I will try. Okay. So you saw the tip of the Moray, which is on the side. Open it, please. I will focus it on it a bit. Okay. So now we will disconnect that, and I will try to push the Moray more. So the problem is that, yes, probably we are outside with the Moray, but you see, as we have only a few amount of liquid, the image will not be so nice. But I think the Moray is open. So now we will close it. So wait. So when you close the Moray, you must at the same time push a bit the body of the Moray inside. And if I have something, we will see a jump. You see, I have some resistance. Okay. You see, I have resistance. Oh yeah. So I think really we grasp a piece of material. So we will remove the Moray now. It's difficult because okay, try now. Okay. So now we remove the Moray. and we have to check. So you know that there were a very nice trial that has been published this year in endoscopy, showing that the adverse events with Morea were not so few, with 1.8% of serious adverse events and even 0.5% of death. So one of the most important thing is to try to avoid to puncture IPMN, especially if you do more than 2 passes and especially if the patient is old. In this situation, you have until 30% of adverse events. So when the lesion is clearly not an IPMN, I think that here it's really not an IPMN. If you do only 2 passes, you really reduces the adverse events lower than 5%. So it becomes, I would say, more acceptable to it. C'est bon, yeah. Okay, so we had a piece of material. So now we will try to do a second pass, and I think I will stop after.
I'll even concentrate.
Okay, I go on inside the lesion with my needle.
Yeah, now you are.
So it's always a bit difficult to push the forceps inside the needle, but when the nurse do it slightly, you succeed. Okay, continue. Okay, you see the bubble that we're pushing?
So this is called persistency, right?
Yes, right. Vas-y, tu me pousses encore, continue à pousser. Allez. So you show us in a very nice study, Alberto, that the perfect number was 3 passes, if I well remember. Is it true?
2 passes.
2 passes. Okay. You see
from Stefano Crino. So
okay.
after 2 passes, if you do the third one, you don't gain anything in terms of diagnostic yield.
Okay. So you saw that we are now inside. The forceps is open, and I can push it on the opposite wall, and you ask the nurse to close gently, and at the same time you continue to push. And you really need to have a resistance when you are removing. So you see here, I'm attracting the opposite wall. It's coming with me, and suddenly you have not a break, but you see that jump of your needle, so of your forceps. Sorry. So it means that you really had grabbed something. But of course, it's only when you remove the forceps that you are happy. Perhaps you can see the if you can have a look with the camera. Give it to me. Tu peux nous cibler dessus là? C'est mieux sur le? Attends. Ah merde. C'est con. Voilà. So you see, we have really a small piece of material. Huh?
So what is your main concern in using this microforceps?
I would say that my main concern is that the main indication for me of functioning a cyst is to try to diagnose the nature of the cyst, and especially to differentiate the big macrocyst, to differentiate serous cystadenoma, mucinous cystadenoma, and IPMN. The main challenge is serous versus IPMN in a lot of cases. And it's true that my concern is that due to the adverse events, it's difficult to really say, okay, you can use it very largely. So personally, I'm more selecting patients, as it would have been for the previous one. I mean, small lesion, for example, 2 centimeter large with a thickened asymmetric wall. In these cases, you can have only 3 diagnoses: neuroendocrine neoplasm, mucinous cystadenoma, or a solid pseudopapillary tumor. And in a lesion that is not too big, less than 2 centimeters, for example, now you have the possibility to treat the lesion with radiofrequency ablation. So you need to really know the diagnosis, and if it's a NAT, you need to know also the grading, and that's perfect for grading.
Can you tell me another thing that is not really about you, but about your pathology? Because at the end you get small pieces, and so I think they need also some training, because at the beginning they are kind of scared to get a diagnosis based on a small biopsy, but they need time. So what do you think about this?
I completely agree with you. Of course, it's very important to warn your pathologist also that it will be a very, very small piece, unless he can even don't see it, and so you consider there is nothing inside, but you have seen something. So it's absolutely true. It's very important to warn the pathologist and to tell him, okay, take time, do all the cut if you don't find any cells, and so on.
So thanks for having the patience and having, I think, the brightness to bring a backup, even though it was very, very difficult. But you show us also, in real life, these things can happen. So you basically had the one patient with a cyst, and then it was not a cyst anymore, and another patient with a difficult to get in to do the biopsy forces. But despite the difficulty, your persistence really made this possible. So I'm really happy you were with us. We will see you somewhere, but we will see you for sure again next year. Hi, Bertrand.
Thank you, Alberto.
Ciao, Bertrand.
Ciao.
Ciao.
Oncosil is a brachytherapy device that utilizes targeted intratumoral placement of phosphorus 32 microparticles in the treatment of locally advanced pancreatic cancer. Oncosil is delivered via ultrasound-guided endoscopy whilst the patient is under sedation or anesthesia. The echo endoscope is slowly inserted down the patient's esophagus through the stomach or duodenum, stopping proximal to the pancreatic tumor. An FNA needle is then loaded through the biopsy channel of the echo endoscope and slowly guided through the gastric wall or duodenal wall into the target pancreatic tumor. Once the needle is positioned within the tumor, the required amount of Oncosil suspension is injected by slowly depressing the plunger. The microparticles remain in the tumor permanently. Microparticle localization is confirmed by SPECT CT from straddle imaging. The patient dose activity at implantation is calculated to deliver 100 gray to the tumor. With a phosphorus 32 half-life of 14.27 days, 98% of the radiation is delivered within 81 days. The beta particles emitted by Oncosil cause direct damage to cancer cell DNA, rendering them incapable of further cell division and proliferation. Through this mechanism, Oncosil stops cancer cells from multiplying, ultimately shrinking tumor masses.
It is my honor and pleasure to be invited to this fantastic meeting. I'm honored. There's so many incredible faculty. Thank you, Alberto, for having me. I've been asked to talk about management of pancreatic fluid collection and beyond. This is the outline of my talk. We're going to go talk about definition of pancreatic fluid collection, the prerequisites, the technique used, go over some data, and then get some conclusion going. Very important to understand exactly the definition of pancreatic fluid collection. Acute pancreatic fluid collection appears the first 4 weeks. There's no solid component. It's due to inflammation. A pseudocyst typically appear after 4 weeks. It's a well-circumscribed homogeneous fluid collection, rich in amylase. A post-necrotic pancreatic fluid collection begins 2 to 6 weeks, and it's really a mix of mush and fluid and debris. Wall of necrosis, which is very well known, is basically a very hard collection that is organized with a nice wall. We don't have to confuse it with a pseudocyst, and it wasn't recognized by the initial Atlanta classification. The management is different from a pseudocyst. This is an acute pancreatic fluid collection. This is a post-necrotic pancreatic fluid collection. This is a walled off necrosis, and this is a pseudocyst. You tell me what is the difference between the pseudocyst and the walled off necrosis? They kind of look the same. Well, the Hansfield unit of a pseudocyst is very low. The Hansfield unit of a necrosis is very high. So the prerequisite is cross-sectional imaging. You need to have skill in EUS and ERCP. You obviously need to do this in the setting of a multidisciplinary approach, and all those cases have to be done under anesthesia because they're very complex. Technique, you have to use CO2 instruments. Antibiotic are needed. Instrument with large channel, 3 millimeters, puncture with a 19 gauge needle, placement of 35 wire, created of a fistula, and then stents. So obviously there's a lot of debate about what kind of stents, but typically when it's a very complex fluid collection, most people now are doing luminapose metal stents. And then we like to do ERCP to see pancreatic duct destruction. So here we are now talking about the indication of pancreatic fluid collection. Obviously, they have to be symptomatic. Size by itself is no longer an indication. We don't like to see fluid collection increasing in size because what is the pathway of least resistance? Vessels. So when I see a fluid collection that is increasing in size, typically the patient is symptomatic and I get worried about the fluid collection eroding into a vessel. So this is a very nice study from Shyam. It's been a while now, in almost 10 years, where he compared surgery to endoscopy for pseudocysts. And obviously, it was more cost effective to do an endoscopic drainage than surgery. A patient goes to the hospital faster, it's cheaper, and his recovery is obviously expedited. EUS is important. It can allow you to see vessels. When you look at the data before and after using EUS for drainage, we literally drop the complication rate by 10% just by adding EUS. So when you talk about pancreatic necrosectomy, you need to understand this is a different beast. It's not only draining, it's really offering debridement. And then very nice, editorial here wrote by Kozarek, confirmed by Todd Barron in 2002, that you have to be committed as an endoscopist to offer necrosectomy. You need to go back, you need to lavage, you may have to put a nasocystic drain, and obviously you have to be ready to think and deal with any complication. Complications include occlusion, infection, bleeding, stent migration. The complication range from 5 to 35%. When we look at the data prior to luminapose metal stent, the success rate was anywhere between the low 70% to the high 95%. How can we explain that? Very easily. Skills. You have centers that are more skilled than others to deal with this, that understand that this is a commitment, that the patient needs to come back over and over and over again. This is not a one-stop shop procedure. It's something where the endoscopist and the patient need to be committed if you want to offer them minimally invasive intervention. Very nice study in JAMA in 2012 comparing open surgery to endoscopy. And you can see here on top of the cytokine storm that surgery is doing, you have definitely less morbidity and mortality. This study literally killed open necrosectomy in the settings of treatment of pancreatic fluid collection. This is another study here that was published in Lancet, which also looked at randomization between surgery and endoscopy. And one more time, the surgery was found to be associated with more complication and more hospital stay. It is not that the surgery is not efficient. It's associated with more morbidity and mortality. I mean, if you fix a necrosis and the patient is running around for months with a fistula and is completely debilitated and able to walk, that is not a success that you want to share, obviously. So I'm not going to go over the pigtail stent era. We don't have time for that. I'm going to focus directly on the new way to do necrolectomy by placing luminapose metal stent. So this is how it started. You puncture the EUS, fluid collection. You deploy the distal flange. You then snug up that fluid collection to the stomach wall, and then you deploy the second flange into the stomach. Then, now that you have a fistula that is safely created, it's very easy to dilate and then get into the fluid collection. You can see the image by EUS are very, very nice. And this is how it started. It started by deploying that luminapose stent, offering a window into the fluid collection. And then after dilation, you can get inside. The very first stent came with a diameter of 10. Then we went to 15. Now we are 20, and the companies are working on creating a 25 millimeter diameter fluid collection. So the new generation luminapose metal stent is what we call a cautery enhanced. You can literally in one movement puncture the fluid collection using cautery, deploy the inner flange, and then same movement, you have to snug up the fluid collection to the wall of the bowel. And then once it's snug up, you typically can deploy the second flange of the luminapose metal stent into the working channel, and then you can free it so that when you do this technique, you have really zero chance of the stent flying into the fluid collection because the flange is already open to the working channel of the scope, so all you have to do is push it out. So this is exactly how we put everything together. Access point and necrosectomy. It's a patient that had a very large fluid collection. You can see here. In this case, we're going to start with one luminapose metal stent and the top of the stomach, and then posteriorly, we're going to access this. At the time, we were still using the cold luminapose metal stent, so most of our access were still done with the cystotome. Here we are entering the collection with a cystotome, and once we have access into the cystotome, we exchange the cystotome for the cold luminapose metal stent. And then once the exchange is done, then we're going to enter with the delivery system, open the first flange, snug up the fluid collection again against the stomach, and then deploy the second flange into the working channel, then out into the stomach. And you can see here that the infection, we're going to dilate this necrosis and then get inside the necrosis and clean. So, sometimes, you're not very satisfied when we have very large fluid collection. In this case, it's very important to think about the multi-gate technique. And in this case, what we decided to do is to place another luminapose metal stent posteriorly, but closer to the antrum in this case, to have better access and better control of this fluid collection. And here we are now entering the fluid collection more distal into the stomach. Now we have two port of entry, and this is great not only for debridement, but to do a lavage. It's very easy now to place a nasocystic drain, and then using one of the entrance points for lavage, and the exit of the debris will be done thanks to the other lumina posing metal stents exit points. So very important to look at the data. The more recent data contain obviously more and more patients that are receiving the lumina posing metal stents, and the data is reinforced one more time that you have more fistula, more time in the hospital, and more mobility when you do surgery. So one more time, when you're discussing with the surgeon, this is not about efficacy. It's about offering a treatment that is as efficacious as surgery, but less invasive. It's all about less invasiveness. So here we are looking at the data of using metal stents. You can see the clinical success is better when you use metal stents compared to when you use plastic stents. And then when you look at studies that specifically look at using metal stents compared to plastic stents, there's definitely an increased efficacy rate. However, there are some data suggesting that the lamps need to be removed within 3 to 4 weeks. So which means that there's a moment where you have to really start thinking about a very easy complication where when the fluid collection collapses, it can erode against the metal stent. So you either have to remove the metal stents or you need to place pigtail to create a buffer between the wall of the fluid collection and the lumina posing metal stent. So lamps are faster, easier, great for bigger fluid collection. It's an open window into the necrosis. They facilitate the next section, the less migration. Plastic stents are cheaper. There's no bleeding when they contact the wall. They're great to access deeper collection. They can be left in place. And finally, the patient can be fed PO at the end of the necrosectomy and sent home. We call that packing with plastic stents and sending home. So what is the best of both worlds, obviously, is if you really are debating and you want to access a very deep collection, you put your lumina posing metal stent and you pack it with plastic stents. So how do you select patients? They have to have symptomatic fluid collection. You have to confirm the CT scan with contrast. You have to drain and access. So it's not only about draining, it's to access point for the necrosectomy. First session, typically we like to cool it off. We place the stent, then we come back. Any collection that is not well organized, stay away from it unless the patient is septic. Nutrition. Feeding tube, very important. You have to prioritize enteral feeding and then make sure those patients don't have issue to coagulation. This is our algorithm at Robert Wood Johnson. All patients admitted to medicine, we start very early enteral feeding with nasal feeding tube. If there's long-term enteral feeding, we do PEG-J. We place plastic stent for single pseudocysts. We do PD stenting for pancreatic leak or stricture. We place lamp for walled-off necrosis with a plastic stent, at least one fluid as a buffer. Every walled-off collection is reevaluated endoscopically at 48 hours. So it's a Monday, Wednesday, Friday schedule. Every one of my partners get to taste the necrosectomy procedure. CT scan weekly. What are the complications? Bleeding, mild bleeding, tamponade, severe, IR. Don't even lose your time. Send the patient to IR immediately. Migration. As long as there's a fluid collection and there is a connection with a wire, for instance, you can bridge the stent. You shouldn't have to worry if you ever lose the stent within the collection, bridge it. You put another stent. As long as you can keep the access, you'll be fine. Perforation. Perforation is extremely rare because most of those collections are opposed to the wall of the stomach or the small bowel. If you have the suspicion of a perforation, we recommend closing the defect, and if the patient is stable, regroup, and eventually consider draining from another side. If there is full perforation with fluid spillage into the peritoneum, you need a washout. Typically, this can be done laparoscopically. This is our algorithm of pancreatic fluid collection. As you can see, our pseudocysts are drained with plastic stent. Walled-off necrosis of complex fluid collection are dealt with lamps that will permit direct necrosectomy for pelvic collection or collection that are very difficult. We typically actually use direct endoscopic necrosectomy by placing an IR drain. So we ask if there's a pelvic collection to place an IR drain, and then we do transcutaneous necrosectomy. It works as well as endoscopic necrosectomy. As a conclusion, endoscopic drains of fluid collection are safe and feasible in expert hand. The success of this technique requires selection of patient and appropriate use of device. New devices do not replace pills. Pseudocysts can be treated with simple drainage, walled-off necrosis, lamps, and necrosectomy. Don't forget the PD, and don't forget enteral feeding. Thank you so much for your attention.
Thank you so much, Michelle. I'm Loretta Trentino. I'm so honored to moderate you after this excellent lecture. Waiting for other questions. I have a couple of questions for you. You are one of the most experts in interventional endoscopy, so I'm lucky to have the opportunity to ask you something about the training which is needed to perform this type of procedure, especially lamps placement and necrosectomy procedure. And after, I have two other technical questions.
Okay, so this is a great question. I'm really happy you asking about training. Draining the fluid collection now belongs to advanced endoscopy in the US. So you have to finish gastroenterology, and you have to enter a dedicated program of formation that include therapeutic endoscopy, ERCP, and EOS. We don't anymore separate the training of EOS and the training of ERCP. They work hand in hand. So what we typically try to do is, while they're learning ERCP, we teach them EOS FNA. Once we feel that they can stage appropriately and they can do a nice EOS FNA, it is time then to let them do pancreatic fluid collection drainage. That's how we kind of escalate the training.
Okay, and the other two questions are about the technical aspect. One of these is, do you perform after lamps placement, do you perform soon after the placement balloon dilation always, or you keep the lamps without dilation? And if yes, why, if you don't perform a necrosectomy in the same session? And the other question is about the device that you use for performing necrosectomy, because we have one or maybe two dedicated device, but we have not evidence enough to use it during our procedures.
Yeah, so it's a great question again. We like to dilate directly after placement of the lumina posing metal stents. When we did the FDA trial, we were trained to actually dilate immediately because they wanted the apposition to happen as soon as possible as the stent is deployed. So when you dilate, two things happen. You open the diameter of the lamps and you oppose the stomach to the fluid collection. And that was something very important. We kept that. So, and I think that's something that is a good idea, especially if a patient comes septic. You want to get the immediate larger diameter in those patients. And the question about doing a necrosectomy in the same session, we have data now that 40% of the patients, when you place the lamps in necrosis, will respond. That means that almost half of them don't even need necrosectomy, okay? Which means that why taking the chance of dislodging and being too aggressive from the very first session? I always tell my fellow about that story of a patient that was transferred from Dominican Republic, literally landed on the roof of my hospital in New York, in coma, in sepsis. Nobody wanted to touch him, not even the surgeon. So they called me, they said, he's in the OR, he's all yours, you're welcome to do what you want. So I went upstairs and I had 2 lamps. I popped the 2 lamps and I left him. 48 hours, the patient woke up and basically was more stable for necrosectomy. So my thinking is, why jinx it? Put the Axios or put even 2 Axios, come back stronger.
Okay, and so what about the device that you prefer and you use during the necrosectomy?
Good question. So I love the basket. The basket is amazing because the basket allows you to grab asymmetric edges, and you can grab it and pull it out, or you can grab and crush them. So basket is my favorite instrument, but you have to be careful with the basket. You got to stay away from the wall because this is the place where the vessel might be. So you have to literally stay away from the wall and work with the basket. The rope net is nice when you have very hard necrosis, okay? Because if it's very mushy, the rope net is not going to do anything. The other thing that I also like when you have a big, well-composed necrosis is actually a snare. You can grab with a snare and very gently pull it out. Finally, for very hard necrosis where you're trying to grab them and everything is basically frizzling, those are cases where we like to use hydrogen peroxide diluted, because the hydrogen peroxide gonna liquefy the necrotic content so that it can facilitate clearance. So you have to really kind of adjust your therapy to the type of necrosis you have. And luckily in my institution, everybody gets to participate on a Monday, Wednesday, or Friday.
Okay, so if I have time, my last question is, do you have an established time to finish each session of necrosectomy? How long it should be?
So a good necrosectomy should be a minimum 1 hour. There is no point in doing a quick necrosectomy. So whenever we call a patient down for necrosectomy, we block for at least 1 hour, okay? Now, let's be honest. The very second or third necrosectomy might be longer, okay? And this is one of the beauty of having advanced endoscopy fellows, is that they get to learn, okay, while experiencing the beauty of necrosectomy. So typically I start, and then I have my advanced endoscopy, do a little bit, and then we switch, and I go get a latte, then I come back, finish my latte, and then do some more necrosectomy, okay? But there's no point in doing a necrosectomy that takes less than 1 hour. It doesn't make any sense.
There is another question from the chat. What do you think of hydrogen peroxide when performing necrosectomy? Do you use it?
Yes. So as I said, I will use it specifically for very hard necrosis. Those are the ones when you can literally hit it and it's like a rock. Those are the cases that you really want to use hydrogen peroxide.
Okay, so I think that we finished our time. So thank you very much, Michel. Thank you, and I have to pass the line for continuing the session.
Well, it was a pleasure. It was a pleasure. Thank you so much for having me.
Direct endoscopic nephrectomy, DEN, is an unmanageable and time-consuming procedure that can be necessary in cases of infected walled-off pancreatic necrosis not responding to drainage, only as a step-up approach after endoscopic ultrasonography-guided drainage, or as a primary treatment in a case of high necrotic solid content. Until now, DEN has been performed with non-dedicated devices. In this way, DEN requires multiple, long-lasting sessions to achieve adequate clearance of solid necrotic content. The multiple endoscopic sessions result in prolonged hospital stay, increased costs, and have potential consequences for patients who must undergo multiple interventions under deep sedation or anesthesia. Necrolid was born from a constant research in order to develop a dedicated and specific endoscopic device for direct endoscopic nephrectomy. The double lumen catheter allows two devices to coexist inside, each of them with its own reference handle. A special monofilament loop with a diameter of 0.9 millimeters, ultra-stiff ends with a rounded tip to avoid the traumaticity of it during use. The internal section of the loop has the peculiarity of being flat. This results in a greater shape memory and a superior synergistic ability to cut and grip the necrotized tissue. A particular basket of equivalent width and length with variable flexibility nitinol wires that give perfect retrieval capacity. The particular basket has no tip, and the junction in the distal part between the filaments with variable flexibility creates an empty space. This characteristic gives it atraumaticity and adaptation to the cavity's object of the recovery of the necrotized tissue. The spiral steel core that connects the handles to the retrieval system has deliberately a small diameter in order to give a rotation called helix effect, essential to allow the necrotized tissue to detach quickly. The transluminal procedure is performed by using a flexible gastroscope with a water irrigation system and CO2 insufflation inserted through the fistula tract or lumen-opposing metal stents. Tissue debris is mechanically fragmented and removed alternatively using the two devices inside the double lumen catheter. The monofilament loop cuts and grips the necrotized tissue, and the particular basket retrieves the tissue. The entire procedure is performed with Necrolid without need for accessories exchange, saving costs and time of the necrosectomy procedure. Necrolid is a new, unique device dedicated for direct endoscopic necrosectomy that permits simultaneous resection and retrieval of the necrotic tissue.
Welcome back, everyone. And that was a truly amazing lecture, Michel. Thank you very much for that. We will show just the end of the transgastric rendezvous procedure that we did not have the ability to show the spyglass in the final outcome of this case. So if we go to the case, you can see we stopped there because at that time we could not pass the stone, intraductal stone, by placement of a stent. So we extracted the stent, dilated the tract, and we now go in with the spyglass. You can see a huge stone obstructing the lumen of the pancreatic duct. The guide wire is removed and replaced with the lithotripsy, and we are now performing lithotripsy of the stone, fragmenting the stone, and within about 5 to 7 minutes the tract was completely cleared from all stones, and you can see the end result of all the stone fragment. The huge stone is fragmented and cleared, and all the fragments were removed, and subsequently a stent was placed. So I think just testifying, if you can gain access to a pancreatic duct with stones, you can perform endoscopic procedures and finalize it by clearing the duct and placement of a stent. So it is my pleasure now to continue with by introducing Alberto back again. Alberto will perform a ERS-guided portal pressure gradient measurement, and Alberto, I think that you're already on track to demonstrate this procedure to us.
Hello, Gianrico.
It's a 62-year-old male. He has evidence of hepatosplenomegaly. He has performed a transjugular liver biopsy, which was consistent with NASH. He also performed the HVPG measurement, which was 13 millimeter of mercury, consistent with clinically significant portal hypertension. He performed a US PPG, which was 21 millimeter of mercury. So he was started on non-selective beta blockers, which was titrated to the maximum dose. So scheduled procedure is repeat US PPG measurement to assess non-selective beta blocker response.
Hello. So we are in the room. Thanks you to all of you. So this is the last procedure. I have to thank the anesthesiologists, the nurses, everybody. They really move patient faster, so we were able to do 3 cases. So this is the last patient. The US PPG measurement will be done by the needle from Cook, the inside the tip needle. which is actually not a needle, but is a system made by a transducer, a 25-gauge needle without a stylet, and a tubing system. We have already prepared the needle, and this procedure will be done using the Fujifilm therapeutic echo endoscope EG740UT, which has I would say a very big channel for today's procedure because it's a 4 millimeter for a 25-gauge needle, so a small needle. So the patient we presented, it's a clear-cut patient where USPPG can be outperform the HVPG. The HVPG that is an indirect measurement of the portal pressure and is done indirectly and is usually done by interventional radiologists. If you look at the Baveno 7 guidelines or the report, unexpectedly there are many new statement about how to perform HVPG that if you think about is something that is going on for 25, 30 years. But if you look at the Baveno 7, there's many points of new way how to perform. There's also how to use it in terms of diagnostic, and then there is the problem of how to use it in clinical studies where there are a mix of diseases. So the patients that we're going to perform the repeat USPG after non-selective beta blockers is an example of a patient who has NASH, and a subset of patients with NASH have a presinusoidal component that basically is underestimated by HVPG measurement. So as you saw that from the presentation, there was a difference of about 8 millimeter of mercury between the two measurements. So other disease where there is a presinusoidal component are primary biliary cirrhosis or autoimmune primary biliary disease, portovascular diseases where there is a vascular component, and these are basically presinusoidal where there is a presinusoidal component, and other small disease. While, for example, viral cirrhosis HBV or HBV related or alcoholic is not presinusoidal, so the HVPG measurement is accurate. So the measurement is done directly in the portal vein and the intrahepatic vein. So I was searching for the portal vein, but then I remember that in these patients it was very difficult to find a spot where to perform the puncture safely in the liver, so intrahepatic, because it is recommended to pass through the liver parenchyma to avoid bleeding. So we can search for so this is the pancreas, so this is the portal vein. So there's other vessels. So that it's very difficult to trace. So you can do here.
Is that a large collateral, you think, Alberto?
Sorry?
You think that's a large collateral vessel?
I think so. But it's difficult to trace it to where it's coming from. So it's just here. So I think it's a collateral. So instead of trying to push from here, where you just move a little bit, I think it's better to go directly into the duodenum and to do. You see, on endoscopy view, there's a lot of congestion in the stomach. So we are in the duodenum. We are two down. So, cava. So we need really to go into the duodenal ball. Sta muovendo. So it happens to you, Scalke, to puncture from the duodenum?
What we do is we avoid puncturing from the duodenum, Alberto, because we're quite concerned that the overangulation of the scope may impact on the artificially elevating the pressure. So we don't do that. If we find that the procedure is not possible from the proximal stomach, then we would not to do this procedure based on the fact that we are concerned about artificially increasing the pressure.
So what about going back to the stomach?
Also looked as if the hepatic veins are very fine.
No, the hepatic veins are fine. Look,
that's not the portal vein. That's an issue. Okay,
no.
there, yeah.
This is the cava. So this is so it's a big. So this should not be a problem here.
No, I see it.
So the problem is so I can follow here. I can also do here.
And just always remain puncture through the hepatic parenchyma.
I know, but it's okay. Probably a little bit is here. Here. I think I'm gonna do from here. So the transducer has to be put at the plebostatic axis. Then we go inside.
So because of the concern of the bacterial translocation, Alberto, you would routinely give these patients antibiotics?
If you have also if you have no ascites, no, we don't do it. Okay, so we're inside. Now you clean the needle. So look at the transducer until it goes back to 0. It's 0. Now you have to go down. So it was 0 when we started. Okay. No. So clean it one time. Okay. Okay. One. Okay. Do the second one. Yeah. So we did the second one. So you clean the needle. and then you count for 1 minute.
Can you just tell us what you mean by cleaning the needle? Is that
So
flushing the
you
needle?
flush the needle with saline to clean up the needle inside the vessels. So how much the second one? Okay, 21. You write it down, right? Okay, third one. Do you always give antibiotics?
We do, because these patients are prone to bacterial translocation, just being cirrhotic. We would, even in the setting of performing this without the presence of ascites, we will give antibiotic therapy, just one dose.
Yes, just prophylaxis for the procedure.
Yes.
Okay, so the mean is 31. Okay, no, so we come out.
But it's really remarkable how reproducible this is. 3 measurements, 31, 31, 30.
So somebody has to keep me the scope. Can you give me the... Qualcuno mi deve tenere l'endoscopio. No, guardi là, qualcuno deve andare di là. Okay, good.
So normally you would try to identify the left, the middle, and the right hepatic vein.
Yeah, but you can do 2 centimeter from the cava, no?
Yes, I think that is what we
But this is big. Did you see that the liver is very small? There's no vessel inside. I take a look, but there's no really other visible vessels inside. So I think this is the best put in pressure. No. So it's already ignoring the patient, so it's not easy to keep. Stable position.
I think this is an incredibly promising technique, although we still have to learn a lot regarding the meaning of this, the reproducibility. But it is a technique with a lot of potential.
Yes. Yeah, we need comparative studies. I think your study that you are doing with Rotterdam and Barcelona, is in a particular patient population, but it's going to be the milestone to do other studies. So, for example, in NASH people, because maybe the presence of clinical significant portal hypertension is underestimated in this patient population. And if you base only on clinical, or parameters, and then, for example, we have sent some cases of PSVD, where really there's a huge difference between the HVPG and the PPG. So, I think it's always sometimes it's difficult because when you apply a new technique, there's a lot of resistance. So I went to give a talk, and there was an interventional radiologist who is basically who does HVPG all the time, and at a certain point he asked me 2,000 million questions, and at a certain point I told him, this is not my job. This is not what I do from morning until the afternoon. So, but I think we will find a lot of resistance. So what are the measurements up to now? So first 13, second 12. And one thing is also to check the response to beta blocker, no? Because this is a very important thing for people with portal hypertension.
So your portal pressure was 31, and your hepatic vein pressure is?
We need the third. No, la prima rifalla quella. So it's 12, 13, and then we had a 20, 23. So we're waiting. We repeat this.
Can you try to show us the tip of the needle in the hepatic vein?
Yes, yes. The most important thing is that it doesn't touch the wall, because if it touches the wall, clearly the value are not consistent.
Okay, that's very nice. Now we can see it very nicely in the middle of the hepatic vein. Okay. I think that's one of the advantages of this technique, because we can be sure that the position of the needle is in the middle of the vein.
So we have 13, 12, and 15. And the mean is 14. And the mean of the first one was 13 minus 14 is 16.
So we have a gradient, a portal pressure gradient of 16
against 21, right?
Yeah.
21 from last time. So to have a response to beta blocker, you need 10% decrease. And this is actually something that we apply to HVPG. So we don't know if this is the same for this measurement, or otherwise HVPG less than 10 milligram of mercury. How much was the first one? Quanto era il primo? So the first one was 21, and this one?
16.
16. So we have a 5-point decrease in the portal pressure. That means that the patient is responding to non-selective beta blockers. So we're going to give you antibiotics under your suggestion.
Excellent. Well done, Alberto. Good demonstration.
It's finished. So we finished from Rome, and we move to another case. Thank you very much.
It's an absolute pleasure to welcome our next two guests. Paul Valkens from Amsterdam will give us a talk on pancreatic fluid collections, and the session will be chaired by Dr. Colm Pham from Norway. Welcome, both of you.
Well, thanks, Scott. Thanks very much for inviting me, and congratulations to you and to Alberto to organize this event. It's a pleasure to talk about pancreatic fluid collections, which is one of my hobbies, I would say. I saw briefly when I entered the site that Michel Kahale already gave a talk about necrosectomy. Would have been nice maybe to talk about it, because I think we would probably fight a little bit. But let's see. You probably heard that talk, and we'll see what kind of discussion we can have. Let me see if I can move on. Yes, these are my financial disclosures. Not too much, I think, and this is probably even more important. Wait a moment, there's one missing. Okay, fine. So these are my financial disclosures. Another disclosure is the pancreatitis working group. The Dutch pancreatitis working group was initiated maybe 25 years ago by Henk Goossen, a surgeon, and more gastroenterologists joined, because the treatment of pancreatitis more and more moved from surgeons to gastroenterologists. And now I think it's been a very, very successful and productive combination of a network really of surgeons and gastroenterologists that really work, share the patients, and work together caring for these patients. I think it is important because it's not a surgical disease, it's not a GI disease, it's a multidisciplinary disease. It's gastroenterologists that move, I think, up to the first place now, but doesn't matter too much. Then surgeons and interventional radiologists and your ICU people, these are also important. So I'm going to talk about pancreatic fluid collections, and the outline of my talk is on this slide. I want to briefly talk about the timing of intervention in infected or suspected infected fluid collections. That's the first subject. Then the second one is a long-term follow-up of a study we did a few years ago, randomized control trial, US guided versus percutaneous drainage. Then I think not completely randomized, but almost randomized study on plastic versus metal, because that's still a big question. And then I end with some remaining questions, which I think we should look into, because still, I think we're doing much better than 20 years ago, but still it's a very, very difficult disease for the patients and for the doctors, because patients are in hospital way too long, and we wait a lot during those weeks that they're in hospital. So a little bit about the timing of intervention. As you see the 3 CT scans below, these are all just acute necrotic collections. And we know when the patient comes in that stage that we should not put drains in or try to put drains in, because it's not really liquefied. Again, sometimes, as in the first and the second, so the one on the left and in the middle, the pancreas itself actually is still pretty well perfused. And in some, and the necrosis is mainly peripancreatic. If you see the one on the right of the screen, there actually pancreas is gone. Everything is necrotic, and that helps. The timing of the intervention is interesting. During my career and during Scott's career, for sure, I think we learned that we had to wait longer. 25 years ago, the surgeon would go in almost immediately to open necrosectomies every 48 hours, and the patients were really, really very ill, and the mortality was very high. And then we learned that we had to delay, and wait until 4 weeks. And one of the questions we had, and that's the topic of the study that I want to show, is whether we were waiting too long. So this is a study that we published last year about the immediate versus postponed intervention for infected necrotizing pancreatitis. Now, immediate is not immediate. The patient doesn't come in with infected necrotizing pancreatitis. It's only when suddenly the CRP goes up, blood cultures become positive, etc. And that's when we talk about infected necrotizing pancreatitis. And what we always said is that you have to wait up to 4 weeks before you start draining. And the question we asked ourselves in the pancreatitis working group is, are we waiting too long? So what we had an expert panel looking at the diagnosis of infected necrotizing pancreatitis. And when there was just the suggestion of infected necrotizing pancreatitis in the early group, the immediate group, you would immediately start draining. Could be radiological or endoscopic, but in these early cases, quite often the collections were not walled off. It was still quite something you cannot drain endoscopically, I think. And the other arm was the late intervention. As we used to do, we try a little bit, we give some antibiotic, we wait a little bit longer, etc., etc., etc. 104 patients, the mortality was not significantly different, and the number of interventions was that neither. All patients in the immediate group got immediately drained. And interesting enough, although all these patients had really a clinical diagnosis of infected necrotizing pancreatitis, in the postponed group, so the group that we said, okay, we'll wait a little bit, we'll try to add a few days, almost 40% of the patients did not undergo drainage. So somehow, things came under control. The antibiotics, maybe, although we always say that the antibiotics don't really penetrate in necrosis, etc., or maybe some other, maybe the encapsulation was better, etc. But it is interesting, and it is also maybe not so good news for the patient. So it still means you have to wait as long as you can before start draining. Early drainage, as we did in this group, doesn't make it better, and the number of interventions, of course, is much higher if you don't have to drain 40% in the conservative group. The other thing is the follow-up of the RCTE was guided drainage versus percutaneous drainage. I think typically when we do these studies, we aim for a follow-up of like 6 months, because that is the acute phase of the pancreatitis. But we also know that many of those patients come back in our outpatient clinic with recurrent fluid collection, sometimes really a pseudocyst, drains that really don't dry up, so percutaneous drains that need other therapy. So we thought, okay, let's make the 6 months follow-up longer, and we actually ended up, as you can see, this study was done in 2018 when we published it. So the study was started in 2014, And these were the original results, where, as you can see, you can probably see my arrow, the primary endpoint was not different between these two. So endoscopic and surgical setup approach were the same in major complications and death. But if you look at two secondary endpoints, pancreatic fistula, of course, pancreatic fistula were much higher in the surgical setup approach because they started with the percutaneous drain, so they had already this hole, and that actually stayed positive for about 30% versus 5% in the endoscopic ones. And the days in hospital, this was a surprise to us. Actually, the days in hospital, if you look at it, the mean 53 days for the endoscopic and 69 for the surgical. So there was a preference based on this study to do a endoscopic step-up drainage if possible. And the study was important to mention, was done with plastic stents, and we'll come back to this plastic stent group a little bit later. Now, as I told you, we did a follow-up of this RCT, and these are the original results, 51 and 47 patients, and we did a long-term follow-up of 83 surviving patients, all the ones we could contact, and the mean long-term follow-up 7 years. And then you see actually nothing much changes. Still, there was no difference in mortality or major complications after 6 months. And if you look at the endoscopic step approach group, then the overall fewer pancreatic cutaneous fistulas persisted. It was not that suddenly the endoscopic patients also developed fistulas, and the number of re-intervention after the 6 months follow-up was also fewer or lower in the endoscopic group. So this just confirmed that also with a long-term study, that really we have to try, if at all possible, to drain endoscopically. And I think probably there's not too many surgeons listening to this presentation, so we're on our home ground, and I think we all can agree on this. Now, interesting enough, and I think I saw a bit of the last few slides of Michel Kahale, what should you use, plastic or metal? And I think many of us, if not all of us, I have quite a preference for metal stenting now, because one, it's very easy to do, or relatively easy. If you have to go to the ICU, you don't need X-ray, you can do everything on ultrasound. And thirdly, it's really much quicker. We know that we can place an axials in an infected fluid collection, especially if it's a big thing. It's probably like a 10-15 minutes max procedure. We also know very well how to follow up, etc. So there seems to be a preference, and we don't know whether that's actually a good idea or not. I brought two small movies. This is a double pigtail stent that we're going to introduce in a collection that you can see here. It's almost an intramural abscess of the stomach. As you can see, there's some water here in the stomach. And typically we would start with the cystotome. The cystotome of Cook, which has a kind of a needle, which you just then put like a cautery on and bring the needle in. Through that needle, you can actually, through that catheter, you can add a guide wire. And then we take the second step of the cystotome, which is a 10 French metal ring, and we also burn that into the collection. That already allows for placement of 2 double pigtail stents, but the 3 millimeters, or the 10 French is a little bit low. Here you see that the 10 French catheter in and 2 wires. So normally we then put a balloon in, 8 millimeter balloon or something that you see here. This is the balloon, and you can actually measure it to 8 millimeters. And once the balloon is in, we know that we can place the pigtails. There's still 2 wires in. Here one pigtail has been placed already, and this is the second pigtail that we usually only then you start looking endoscopically, because you have to be careful. Combining endoscopy and US is kind of not possible, and sometimes you lose your image there. So this is a procedure not that difficult, but you need experience, and 1 in 10 actually is quite difficult because maybe you lose a wire, something happens, etc. So let's look at the next image. This is another collection, a little bit similar, quite a lot of fluid as in the other one. And this is a luminopulsometric stent. This is a 20 millimeter Boston Scientific stent. As you can see, we check for vessels. And then with the first step of the axials, that's number 1, you go in deep. The second step then will be to develop the inside flange, as you'll see in a moment. That's step number 2. And then step number 3 is you always need a little bit of time for that to change. You can reduce you can remove the connection, the cautery, etc. And then you have to pull that stent close to the wall because you don't want to lose the stent inside. And when you really pull it quite snug and you see this tip of the stent hitting the introduction system, then usually you know for sure. You open it inside the endoscope and then slowly push it out. And that's the way to do it. I think Michel Kahale probably has made a point that you can then continue immediately with a direct necrosectomy. I don't think there's enough evidence for that. I think that's one of the studies we should probably do shortly. Let's go to plastic versus metal. That's a little bit what I said. So from the earlier study that I talked to you about, we had 51 patients with plastic stents, and we didn't do a complete new RCT, but we added a new prospective arm with 53 patients treated with lumps. Identical clinical protocol. Both arms were prospectively studied, and the primary outcome really was need for necrosectomy. How many patients need necrosectomy in this large stent? And we also hoped, and we thought that hopefully the necrosis would drop out spontaneously, but we're not sure about it. And this is the result that we published this year in gut. Again, it's not a perfect design, but I think it is both arms were prospective. And we saw in the lungs group, and we did not do a direct necrosectomy. We waited until it was needed because infectious parameters went up again. And you see the need for endoscopic necrosectomy was 64% compared to 53 here. So there was absolutely no difference in the need for necrosectomy. Sometimes difficult to understand, but that's typically what it was. And then the second one, also interesting, of course, bleeding. There was no difference. 17% of bleeding in the lungs group and 22, and that's just I think what we see in these large collections. So that was the conclusion was at the time there is still no difference between plastic and metal for use guided drainage of infected wall of necrosis. Now, remaining questions, because this is the evidence I'd like to show you. I think we have to do something about the optimizing of evacuation of necrosis. We really are. That's probably one of the points why patients are too long in hospital, and axials has not solved that. And the other thing is what to do with PD disruption. How can we evacuate necrosis effectively? We need to do something else. We need something like improved mechanical necrosectomy in the device. That's all one of the devices. What is the EchoLid, which is kind of a Dormia mask, but much firmer. So that could be helpful. Hydrogen peroxide has been suggested, but never really well studied. I don't think that direct necrosectomy, because if you do direct necrosectomy, it means 100% of the patients need a necrosectomy, and that's probably not what we want because about close to 50% don't need a necrosectomy. The other tool, I think, if you're a little bit older, we've seen this about 10 years ago. This is called the endorotor, and it was then, I think, first brought to the market for removal of flat neoplasia in the colon. Was not very successful there because you had no pathology. And I think there was one case series from Rotterdam studied, published 2 years ago, 12 patients that altogether underwent 27 procedures with a mean of 38 minutes. That, I don't want to be too negative, but that almost answers the question. This is also not that more effective because most patients that we do necrosectomy, I think, undergo around 3 necrosectomies. There is a new larger caliber instrument. This is like a 3 millimeter, there's a 6 millimeter instrument which will go alongside the endoscope, and there's a study already designed and maybe active already. So that could help. There's actually a small, very small knife rotating in the point of this catheter that kind of scrapes off the necrosis. And then one of my final slides is what to do with possible PD disruption. Is that maintaining it? We really don't know enough. We need to do more studies. We did just an international expert survey with some case vignettes and invited people to see what they do. And in the diagnostics, most people say, well, you probably, if you think about pancreatic duct integrity, then you need a MRI, MRCP with about 80% agreement. Yeah, probably very easy. The other one with 93% agreement was, well, if you have a fistula that is continuous, then you need to measure MLAs for evaluation of pancreatic duct integrity. And we know if the MLAs is maybe 100 or 200, it's not pancreatic fluid. And if it's way up, then it is. So, but that doesn't help as much. And what did people think about treatment? I think what you see here, treatment 1, endoscopic transluminal drainage for infected necrosis. Yeah, that's probably better because you get kind of an internal fistula, as I showed you in another study. And this is, I think, still open for discussion and for debate. Do you need to evaluate the pancreatic duct integrity prior to transluminal stent removal? I think we do now in a prospective fashion, but I don't think you always can say much about it, because we see many patients with a disrupted pancreatic duct that actually after removal don't develop any problems, and some others do and get a disconnected pancreatic duct syndrome with the tail and the collection, etc. That's an area where we still have to improve, I think. So in conclusion, Schalk and Mr. Chairman, no advantage for early drainage of infected necrosis. Still, I think the idea would be to wait about 3 weeks or a little bit more. Of course, there are exceptions. Sometimes after 10 days or 2 weeks, you have a perfectly walled off collection, and then if it's needed, you can drain it endoscopically as well. I think endoscopic drainage is clearly also in the long term preferred over percutaneous approach. Salvage fundamental stents and pigtails are equally effective, lumps in this case, right stents with lumps. Pigtails are cheaper, of course. We have a financial issue in the hospital for next year. I think everywhere around the world we have an issue, and we decided for our patients with infected necrosis, we'll probably go back to pigtails because we can save some money. Of course, not when the patient is very ill in the ICU, because it's so easy to bring in the lumps. Necrosectomy is still one of the caveats. I think it's complex, it takes multiple procedures, and the fate of the pancreatic duct after necrotizing pancreatitis is unclear. This is an announcement of our Amsterdam US Live, semi-live in Amsterdam, which was in June already, but next year, 26th anniversary meeting will be there, and I hope to see you there as well. So, Schalk, with that, I'd like to end my presentation.
Thank you very much, Paul. That's a great presentation. So I would like to thank Schalk and Alberto for the invitation that I'm able to chair one of my endoscopic heroes. Well, we have only one question from the audience. So Oscar Kahide, he asked, what do you think about EUS necrosectomy versus laparoscopic transgastric necrosectomy?
Yeah, I think it's a good question. I think once you have drained it primarily, it's just endoscopy that you need. So I don't think we never go in with the US scope in the collection. I think it's not necessary, maybe dangerous. But I think laparoscopic necrosectomy for me is one step too far. It's more invasive. I see interesting publications from American surgeons that like to do that. Maybe they can be more complete in one session. That may be a difference. Because when we sometimes had the percutaneous drainage and they did one of those, they put a laparoscope in there, and they can actually more effective. They can use different tools. So they may be able to drain it in a fewer sessions than we can. That's another issue. Yep.
Well, if I can ask a question, thank you for this incredible overview. I think it's just clear how the Dutch and the pancreatic group has changed completely our approach to drainage of collections. But I just want to ask you, I'm very perplexed by the fact that necrotic collections can disappear in some of these patients. Do you think that can happen because of spontaneous fistulas forming and drainage occurring via fistulas? Because it's otherwise very difficult for me to know why they simply disappear.
Yeah, I think one of the points for sure is spontaneous drainage. I think that doesn't happen too often. We see that suddenly the patient has high infectious parameters, and then the day after he feels much better. And if you make a new CT scan, you see a lot of air. If you see a large amount of air in the collection, that's usually spontaneous drainage. But I would think that happens in 10% max, maybe a little bit more, but not much. What actually in this case was the question was whether you could treat them only with antibiotics. It doesn't mean that all the collections were completely resolved. Some people still have a collection, and it takes much longer for the collection to disappear, of course. But it does happen, and it was surprising to us as well. It was almost 40%. So they didn't need endoscopic drainage. Still, they had a long follow-up and a long time in hospital.
Hi, Paul. Great talk. I really enjoyed it. What do you typically do in institution about the pancreatic duct in those patients?
Yeah, typically we do the MRI now for an inventory, and we normally don't act on it yet. So if we see that the pancreas, well, if there's a clearly dilated pancreas, then maybe we will do something. Otherwise, we'll just remove the stent, try to put it back, which is not always very easy after 4 weeks or more. Then if you really want to place pancreatic plastic stents instead of the lumps, I think you would go in earlier, maybe after 2 weeks or 3 weeks. Well, I'm not sure what your experience is, but the number of patients that have a pseudocyst after this is not that high.
Right. I think we do a lot of second-enhanced MRI RCP, and that really has been our selection process to decide if the patient can have an ERCP or not. And you're right, the majority of the patients don't need an ERCP, but we still do the SMRCP.
What percentage of you, the fact that you have a positive second MRI?
Probably positive in terms of stricture or leakage that require treatment. I would say no more than 15 to 20%.
Yeah, okay, so that fits a little bit. There's also some recurrence. Yeah, yeah, interesting.
But in my institution, we also use to do the combined lumps and the double pigtail in cases where we suspect the disrupted duct syndrome. So so it allows you to remove the lumps and then leave the double pigtails for more permanent.
And do you do it earlier? How many days after introduction of the lamps do you do pigtails?
No, it's in fact in the same session. So
Okay.
so if you can it depends on what kind of lamps you have available, but you can use the same introducer to puncture, because the lamps we have the introducer is already 10 French. So you can just place the guide wire, and then you can place, for example, 8.5 French taper tip double pigtail, and it will just enter without further dilatation. You can do it pretty quickly. So if you know already and you can plan, then you can just pump as this 2 cents after each other.
Yeah, so you do the metal stent, then you do the plastic through it.
Yes.
And when you want to remove the lamps, you
No, I place the lamps, and then I reuse the introducer of the lamps, and then place parallelly or nearby
okay.
a double pigtail. And then later I can dilate the lamps and put an additional double pigtail through the lamps. But I always have a additional double pigtail alone next to the lamps. So when you remove the lamps, you can leave the double pigtail. But the risk is that if it's you can have a lot of as a quick collapse of the pseudocyst collection, and then you have to be in a hurry.
Yep.
Yeah. There is a question from Paul Jobel. He's asking, you leave a plastic stent indefinitely?
Yeah, maybe not in a 25-year-old. Then maybe at one point we get the patient back, but yeah, very low threshold to leave them in forever. And to be honest, we follow those patients, of course. I don't think we have seen any problems, no disintegration of plastic stents or whatever. I think Jacques de Vier also did a very nice study, and I think that was a randomized study. They had a higher number of recurrent collections, but yeah, I think he showed that you can leave them in many years, no problem.
There's another question from Federico Desideri. I don't exactly understand, but he writes, which is your plan in necrosectomy? What about necrosectomy? Gastroscopy to clean the collection, and how many times and how many days after deployment of lamps?
Yeah, I think what we normally do, we try to wait 48 hours. That usually is also okay. I think the recurrent problem is usually more than 48 hours. If we get febrile CRP gets up, then we go in with a standard gastroscope through the lumps. That always is easy because especially if it's a 2 centimeter lumps. Sometimes the necrosectomy is a little bit hindered by the lumps, because if you have a big chunk of tissue, then the lumps kind of get stuck. And sometimes you pull the lumps out as well, but you can reintroduce it if you want to, or change for pigtails. We try to clean it out, so that usually doesn't work in the first session. So we usually will plan the patient after 48 to 72 hours for the second session, and we'll continue usually 2, 3, sometimes 4 sessions to remove as much. If the collection is really solitary, that's I think almost always enough. If there is another collection which goes down deeper, for instance to the left kidney, etc., and below, I think you should add a percutaneous drain because it's rare that you can remove all that necrosis from the stomach. And I think you can be much quicker. You put a percutaneous drain, you can flush also, that's helpful. And the first one you take out when everything is going well is the percutaneous drain, and later on you take out the stent.
About this, Mohammed from Orlando. Quick question about if you're suspecting disconnected pancreatic duct and you want to do an ERCP. One question is, are you doing a number of those patients on a routine basis? If not, and if somebody wants to do an ERCP, when is really the best time to do a pancreaticogram? Is it during the second session of necrosectomy, or when you are trying to change the lamps with the plastic stents at that time, or towards the end it's completely resolved and you're thinking about I need to remove those stents? Should you do a ERCP at that time? Because majority 80% of these patients, even after you remove those stents, likely are not going to have a recurrence of collection. So what is really the best time to do that ERCP? Like you say, 80% don't need an ERCP, so I think you should do it as late as possible. If you want to do it in the first session when there's a big collection, anatomy is different, the patient is ill, so I would definitely leave it alone. And the fact that there is a pancreatic duct leak when you have the acute phase doesn't mean that it will persist. So I think I would do it as late as possible. So if you really think it's necessary, I think the MRCP or secretary MRCP makes much more sense because you get more dynamic information. If you really feel you want to do an ERCP, then I think it would be as late as possible. So maybe when you change stents. If that's what our practice is, like towards the end, when we're thinking like, okay, remove that, if we want to do ERCP, that's the time we do usually in our center. Yep.
No, I wonder if you have cases where you have the lamps saying you realize you need it more than 4 or 8 weeks. What do you do? You just keep it, or do you want to change? Or?
Yeah, we'll change after 4 or 5 weeks. Yeah, I think we always put them out. It's interesting enough, and Mohammed will know very well. The studies at the time from Orlando showed a very high bleeding rate. I think we all experienced some bleeding. It doesn't seem to be as prominent now when we use them more, although the design has not changed. But yeah, I think it's a good habit to remove them at 4 or 5 weeks. That's what our practice is. Within 4 or 5 weeks, we remove those and change it for the plastic stents.
Okay.
Well, you mentioned that it is sometimes that you would consider placing plastic stents also to be more cost effective in the next years to come. Are there ways to predict what collection will respond to plastic stents? Because in our practice, if the collection is really filled with necrotic tissue and we would expect the patient to need to undergo necrosectomy, I think there's not, in our opinion, extra value of placing NXIOs, but rather place plastic stents because you in any case need to go back to perform the necrosectomy. So how do you decide?
Yeah, I think that's about the way we would go. A large collection with a lot of necrosis, it's difficult to predict that because EOS is not very reliable, CT is not, probably MRI would be best. I think that's probably the way we are going as well. Yeah, you can save just in the Netherlands. I think the actuals is about 3,500. If you use 2 wires, 2 pigtails, the system, you probably are somewhere between 500 euros, etc. Yeah, if I can do it in 20 patients next year, I save about 50,000 euros, and I can use the lumps on other indications. I'll definitely use them, but then for gastrogenostomies, etc.
I must say this was an excellent talk. I don't know if there are any more questions that we need to consider. Otherwise, Alberto, I think we probably need to move on. And I would like to thank both Paul for his excellent talk as well as for Kaan for moderating the session. Thank you both.
Pleasure.